you to tonight's Twitter space, which is dedicated to serving our brother Dr. Anthony Ruhanga Maisha. Um, yes, we shall be starting shortly as we wait for other people to join. Um, I welcome you in your different capacities. Uh, yeah, and we look forward to having yeah to to having our discussion. First of all, of course, to raise awareness about doctor's condition, but also relate this uh, to the general, to a much wider context, because it's not just the doctor who is experiencing this, um, uh, who is experiencing this problem at this time. There are many, many others, and not just experiencing the condition per se, but also the attendant challenges like treatment, affordability, accessibility, all those issues. So, and of course, many are not privileged or disposed to raise funds. So it becomes a real, real problem. So for the majority, actually being diagnosed with end stage renal condition is a verdict, is a death sentence for the majority of the people, because they are not in position to raise funds, to access treatment. First of all, treatment is not available locally. If they're going to do a kidney transplant, and they've got to travel away. So all these are costs that are likely to be prohibitive for the majority of Ugandans. So I think discussing doctors' problem, doctor's condition, and doctor's situation, we shall be speaking directly to the system, the healthcare system, that is, you know, in many ways dysfunctional. It's broken, and that is very, very, very sad, ladies and gentlemen. Um, yes, according to the World Health Constitution, uh, you know, uh, health is a fundamental right of every human being. Therefore, states are actually obliged to ensure that citizens have access to timely, acceptable, and affordable health care. And let me add, the healthcare should also be of the quality that is desirable. Sadly, in the context of Uganda, this is not the case. Um, it is a challenge, and so we've got to work against those odds and make sure that our brother survives, um, gets the treatment that he deserves, and he gets back to work. Our position of a doctor is always a privileged one, in a sense, but it's also an asset to a community. So I think saving a doctor is actually saving a community. It's just like when you deal with a mother, with a woman, you're dealing with society. So I think there are some parallels there. So a doctor has a lot to give back to the community, and therefore it is income. I mean, it is imperative that we do what we're doing. As we wait, I'll maybe just pass the mic back to comrade Sarah. Sarah, over to you. Thank you.
Right. Thank you so much, Comrade Joe, and welcome to the space tonight. My name is Sarah. I'm so pleased to have you here today as we chat out a way forward. And this topic is not new on this platform. We have previously visited it from different angles, but obviously this is a humanitarian topic tonight. And really humbled that we're doing this to save a doctor to save a life, really. Before we start, I would like to invite back, to welcome back everyone who was here previously, and I would like to welcome everyone who is joining us for the first time. Please feel free to ask for the mic, and I would like to invite Mark Kunihira to request for a mic to co-host. We are co-hosting with the doctor's brother, who will share a few things about the doctor. I've tried to give you the mic, but for some reason, you're not accepting it. So if you can, please request for the mic, and you'll be accepted. I would like to invite Dr. Nyanzi to request for the mic as well. And I would like to, yeah, perfect. I think you have the mic. However, it seems to be connecting. We are waiting for a few other people to join us. Some of them were with us previously, and others are obviously here for the first time in hoping to, yeah, to create awareness around this particular issue, the doctor's health, as well as chart a way forward, ensure that he gets the help that he needs in a time that in an appropriate time. Thank you so much. Mark, are you able to pick the mic?
It
Uh,
appears Mark is having challenges, but sure. I think as we wait for the numbers to grow, we let's just have a bit. Let's engage in a conversation and just really try to speak to this problem, and in particular in relation to Dr. Anthony Ruhanga Maisha, but maybe to kind of broaden the discussion as we wait. Dr. Nyanzi, I welcome you to this discussion. Dr. Nyanzi, are you able to speak? If you can unmute your mic, please.
Yes, Joe. I missed what you said.
Now, really, we're just going to engage in some informal discussion as we wait for the numbers to grow. Just discussing the problem, the problem that doctor is facing right now as an individual,
Okay.
but maybe we can even broaden the discussion, in the greater in a much broader context. Personally, this topic is close to my heart. My own dad, my father just passed away 30th of 30th of May. He had also been diagnosed with end stage with an end stage renal condition, and the challenges were very were just immense. Actually, from an economic standpoint, it was very expensive. Um, because it happens that I'm not in the country with my dad, so all we had to communicate and manage his treatment, away from home. He had to go, again. You tried in different hospitals, and most of these hospitals are terribly expensive. And I can just give you a scenario like a month typically. Sometimes we're paying around 50 million Ugandan shillings. So for the average Ugandan, that is way out of reach. So in other words, how many? I mean, doctor, from I don't know what exactly your specialty is, but I think you kind of probably you're better disposed to discuss this problem. Um, what is the on average? I mean, how many Ugandans are having similar problems like Dr. Anthony Ruhanga Maisha?
Um,
If you have the statistics.
Thank you, Joe, for the question. I do not have the figures, but maybe I'll be able to have that information in the next space. But actually, the number is quite high. We do have in the recent past, maybe 2 to 5 years, a number of Ugandans that need to go for hemodialysis have increased. Recently, I think either the end of last year or early this year, the first out of Kampala hemodialysis center was opened up in Lira Regional Referral Hospital. So the need is quite big. So a number of people actually are flocking to Kampala. Of course, the private centers, but the government center is really Kirudu National Referral Hospital. So the need for this remedy is really quite high and growing by the day. Probably also maybe the other thing that comes to mind, probably we'll be able to get Dr. Joseph Ogavu, who is the nephrologist taking care of Dr. Buhanga Maiso, to really give a more detailed picture of this condition in Uganda. Yeah, thank you.
Thank you very much, Dr. Nyanzi. Okay, much as the facilities are there, and of course they're still quite
Uh,
limited and quite
Joe,
restrictive.
Joe,
Yes, please.
Joe, let me interrupt
Yes,
you a bit.
please.
I've just seen a person who can answer is on the call. Dr. Robert Kalyesubula is one of the leading nephrologists in the country. I think he can give us a picture of the renal disease. Dr. Robert is on call. Maybe he can be given a mic to say something about this here.
Absolutely, absolutely. Dr. Robert Kalyesubula, I welcome you to tonight's discussion. We're going to give you a mic, and I think you're better disposed to answer some of these questions. And I think let me recognize Dr. Robert Kalyesubula. Actually, I Doctor, you might not know me, but actually, Dr. Kalyesubula was one of my father's doctors. So he was very, very involved in trying to save my father's life. Sadly, it had come to a point that he could not be saved. So I recognize the very, very important work that you're playing in saving, many citizens' lives. Doctor, I just posed a question. You probably just joined. I don't know how much you heard, but we're just looking at the situation in general as we wait for more, for more, for more people to join the space. What are the numbers? I mean, at national level, what are the numbers of Ugandans who are experiencing similar problems, problems similar to Dr. Anthony Ruhanga Maisha? Over to you, Doctor. Thank you.
Yes, thank you very much. And thanks to everyone who is trying to save Dr. Anthony's life. We have about two sources of statistics. One study that we did in Wakiso and another that we did in Chamulibwa. And we found that about 0.05% of adults above 18 years actually have kidney failure, which is kidney failure stage 5. So that would translate to about 20,000 Ugandans who would actually need a transplant or would be in need of renal replacement therapies. In the other statistics that we have, we know from the records in Mulago, Kirudu, and other places that of those who need to have dialysis, actually only about 10% do access it, largely because of costs and most times distance. Although the Uganda Kidney Foundation, for which I'm president, is trying to address the issue of inequality through working with the government of Uganda and a private company called BHL. So we are now trying to have regional dialysis centers, but the problem is far from being solved. And if you look at the just kidney injury that is having an abnormal creatinine, we found that up to 21% of Ugandans have a glomerular filtration rate less than 90%, meaning that 1 in 5 might be at increased risk of developing kidney disease as adults. And we know that even now, in one study that we did with MRC UVRI, that finding a single abnormal creatinine, especially if it is it makes your GFR less than 60%, meaning 60% of your kidney function, then your risk of dying in 5 years is 6 times above those who have never had an abnormal creatinine. So the problem is really huge, but I think the challenge is in the diagnostics and then access to care. I submit. Thank you very much.
Uh, thank you very much for that for that in-depth answer. Let me just my colleague the hostess has her hand up, and then I'll just get back to you with a follow-up question. Yes, Comrade Sarah, over to you, please. Thank you.
Right. Thank you so much, Comrade Joe, and thank you so much, Dr. Kalyesubula. So pleased to have you on the show here with us today. My one question in this regard would be routine checks. Say, for example, are we doing routine checks for people who are at high risk of having kidney failure? And if so, is there a system that actually supports that to sort of prevent people from getting to this stage? Because I'm looking more at a solving the problem before, or having a solution before actually the problem becomes too big. So I'm asking about routine checks, or do we even advise them to do routine checks every 6 months or whenever, so that they don't get to this stage of the kidney issues? I hope I'm making sense. So that's my question, Dr. Kalyesubula. Thank you.
Thank you very much. I came to be a discussant. It seems like the questions will keep coming to me as an expert. Anyway, thank you. So unfortunately, we do not have very good guidelines, particularly for Uganda, for screening kidney diseases. So most people adopt Western guidelines. I think where it is categorically recommended with clear guidelines is in the sickle cell. Those who have sickle cells, there is some clear guidance on when they should be tested. And those with HIV, before they are started on drugs that can injure the kidney, there are some guidelines that can be used and encourage people to be tested. But by and large, we know from the scientific point of view, even in developed countries, that routine screening for kidney disease using a blood test called creatinine and a urine test called protein in urine is not cost effective, except for those who have increased risk. Now, the definition of that is largely coming from developed countries where people get kidney disease and comorbidities when they are much older than 60 years, whereas our population is much younger. The average age of a person who develops kidney disease in our setting is around 35 years, as opposed to those from developed countries. So, to answer your question, for now, everyone should educate about themselves about the risks of kidney disease. And if you have any of the following, which I'm going to try to mention, is not exhaustive. If you are hypertensive, if you are diabetic, if you are on chronic medicine lasting more than 6 months, whenever you visit your doctor, you should perhaps ask them about the status of your kidney. And that question should always go to the doctors when you meet them. We know that there are also risk factors that are acute kidney disease occurring within a week. That gets a bit difficult, and that largely relies on the medical workers who are seeing the patients. I'm going around circles because we really don't have a guideline in Uganda for screening kidney disease, yet it is not so expensive. But because it involves taking a urine sample and also taking a blood test, it is rather a bit more expensive and not routinely done. So the best shot is actually for the individuals to be empowered to ask about the status of their kidneys. I submit. Thank you very much.
Thank you very much, Dr. Kalyesubula. I apologize. This was not really meant to be some kind of a symposium to discuss uh, these very medical and technical issues. However, for purposes of awareness, I think it is pertinent and it is timely. Just good. we're just going to have like two questions, and then we shall really get into delve into the campaign itself, and that is the purpose for which we've convened here. Just my final question. I was really looking at the affordability bit of it. Yes, we know that the treatment centers are well, they've been, they've been concentrated in Kampala, and I just heard from Dr. Nyanzi that I think they have another center now in Lira, which is a good thing. But in terms of two things, are there any awareness campaigns, to the public, so that people know the risk factors, just as you've mentioned? And secondly, in terms of affordability, what is being done to help the people access treatment? Because I know from the experience of my father, this was it was prohibitively expensive, just managing the dialysis and other, attendant complications that arise, especially if one is advanced in age. So that would be my final question, if you may, Dr. Kalyesubula. Thank you.
All right, thank you very much. I guess the cost of doing dialysis is really very expensive. It depends on where you go. Initially, actually, even in Mulago Hospital, when we had just qualified in about 2012, the cost of dialysis was actually 300,000 per session. But before dialysis can be done, dialysis is like an artificial kidney. When the kidney is sick, it accumulates a lot of toxins that the body is not able to remove. So when we do dialysis, we have to get access to your blood, take it to a machine, which takes out the toxins and then returns that blood back to you. This is a temporary procedure that does not cure the primary problem, but is able to keep people alive by making sure that it takes over the function of the kidneys for the time that person is on that machine. So the person often needs to have dialysis. We have two modes of dialysis. We have hemodialysis, where we take out the blood, take it to a machine and clean it. And we also have what is called peritoneal dialysis, where we put a small and then pump water into your tummy. And that water has a high concentration. It's called a dialysate. And then it pulls out water and toxins. And after about 4 hours, we take that water out. After it has removed the toxin, that process is done several times. Unfortunately for Uganda, we are not able to do peritoneal dialysis. So we do what is called hemodialysis, which often requires the patient to go to a center. So the direct cost that we incur would range between 80 and 400,000 Ugandan shillings per session. And for inadequate dialysis, a person needs about 3 sessions a week. So that's about between 300 and 1.2 million shillings per week if you are to be maintained on hemodialysis. Then obviously the majority of people can't afford that. And as the previous speakers have said, we have centers in Kampala, so you have to maintain the other drugs. You have to travel from wherever you are to the big centers. Maintaining dialysis and staying on it are definitely too high. I'm presenting, I often say that the doctor with easy 1 million now, like the interns are earning 1 million a month. If they got kidney disease, they would actually not be able to afford half of the dialysis need they would need to have. So you can see that dialysis is mainly out of access for most Ugandans. Again, thank you very much.
Thank you. I think doctor's having some challenges with that. We're just taking two final questions. Then we kick off the campaign. Poker, please come ask your question, and then we shall. Thank you. Poker, unmute and ask your question, please. Thank you.
Hi, nice to meet you all. Thank you for giving me this time to have to submit my question. My question goes to all the medics who working in these hospitals. I'm just wondering, Dr. Was it Dr. Kalyesubula just say that you have done like analysis of part of Uganda that 1 of 4 is going to have a kidney failure. And that means that, let me say, like in 2 years' times or 4 years or 10 years, let's assume in 10 years, we have that problem. I'm just thinking, if a normal Ugandan cannot afford a normal dialysis, how are you going to sustain this system? Because for me, it looks like the system is broken. You're working in the broken system. Nobody's doing anything about it. How are you going to sustain this problem? Because I'm seeing problems everywhere in every section, but you are all quiet about it. How are you going to maintain the situation?
I would like to answer that. I think I'm the most qualified. I think I get your position, but it's not true that we are quiet about it. The little dialysis that you are seeing
Sorry,
is
doctor, we've lost you
living
a
here.
bit.
Can you hear me now?
Yeah, yes, loud and clear now, doctor. Thank you.
Yes, thank you very much. So I would like to kind of disagree with the previous speaker. You know, in third world economies, Uganda is not so unique. When I qualified, we were only 3 nephrologists. We are now 14 nephrologists in Uganda. When I qualified in 2012, we had only 3 dialysis machines in Uganda. Now we have over 200. When we qualified, there was only 1 unit of dialysis. We now have over 25 dialysis units. When I qualified, dialysis was costing in Uganda 300,000 shillings, as I presented earlier. It is now 60,000 in the private facilities. We have
Sorry,
fought
we've
now
lost you
to bring
again, doctor.
Ugandans and teaching them. Hello?
We're losing you, doctor. Come again. Thank you.
Hello?
Yes, I hear you now, doctor. Yes, doctor, I hear you now. Thank you.
Yes, I am. I don't know when you last heard me, but I'm coming in defense of doing some work. So we have made a lot of effort. We have created the Uganda Kidney Foundation, which actually has held over 150 sensitization seminars since it was created in 2012. We have also gone further to train specialists. When I qualified, we are only 3 nephrologists. We are now 14 nephrologists. It takes about 150 million to train a nephrologist. So it's not an easy task. And also, hello?
Yes, so I hear you now. We're just talking about the cost of training a nephrologist. Yes, carry on.
Yes, the cost of training a nephrologist is very high. So we are not seated, and this is why we are here. The issue of kidney and most of these non-communicable diseases, just like malaria and other diseases, they are not going to be fought by specialists. They are actually going to be fought by each one of us because we are all victims, or we could be victims at one time. And this is why we come to these fora, so that where Parliament, and that's why you're seeing dialysis being brought up. It was because of the Uganda Kidney Foundation, where we went and presented the case to the Ugandan Parliament. So a lot of work is being done, and would like the majority of doctors, individuals, relatives, friends to join this. This is what's happening for I see a lot of experts here, and it has happened to the lung diseases. So we need to do the same for the need effort, but it's not true that nothing is being done. Thank you very much.
Thank you very much, Dr. Kalyesubula, for that response. And I really think, in all fairness, I think that is a multifaceted question. Yes, there is the part of the professionals granted. However, I think really we're speaking to the health infrastructure, which is broken, and which is very to an extent quite dysfunctional. Uh, it is under resourced, it's understaffed, and But again, from your narrative, I think we've made some progress, but a lot more ought to be done. And of course, it's absolutely not the fault of Dr. Kalyesubula and other medical professionals who are working there. So I think the conversation, the discussion is timely. We need to have these debates. The government needs to put more resources, I think, in the health infrastructure. Absolutely, we need to improve the working conditions. And I think times when there have been, for example, strikes, I think the grievances have been rather narrow. I think the scope should be much wider to speak about the infrastructure, the working conditions, the salaries. For example, right now, the Dr. Anthony Ruhanga Maishu should have had insurance. He doesn't have. So all these things, really, that packages is important even for the doctors to thrive in their work, because it is very frustrating to work in an environment where you are incapacitated, you don't have the equipment, you don't have the medicine, you don't have, so we actually we are very sympathetic to the doctors who are operating in these conditions. So the debate should be like speaking to the healthcare system, the infrastructure, that the government has a duty. As a matter of fact, in my introduction, I said the World Health Organization actually stipulates that healthcare is a fundamental right to every human being, and the states are obliged to ensure that citizens have access to timely, acceptable, and affordable healthcare. So we should not even be here. Dr. Anthony should have access to to quality treatment, but sadly, it costs. And we see that a common man who doesn't have the privilege of networks is definitely, when he gets this diagnosis, he's condemned to death. That is what it is. Yes, I think let me bring in Dr. Mgenya, and then I bring in Dr. Sarah. Sorry, Comrade Sarah, and then we kick off the campaign. Dr. Mgenya, please, over to you. Thank you.
I'll say good morning. It is 10:36 in the United States. Joe, I just wanted to say kudos to Dr. Kalyesubula. Is it Kalyesubula? Yes.
Yes, Dr. Kalyesubula.
He has said something
correct.
he has said something that I wanted to hear. He has said something that I wanted to hear. Wanted to know, where are we with kidney problems in Uganda? Now, I am in a hospital where heart surgery, kidney problem is just like ABCD. It's treated like malaria, but that's not what I want to speak to here. The question that was asked was challenging him, but that question challenges all of us. Active citizenry. In the United States where we are, you don't separate politics from the citizen. You don't separate politics from medical care. They all relate. So, to me, I think we need to speak to the citizens, because most decisions that we are speaking to here are made by ignorant citizens. Now you need to raise the quality of citizens in reasoning in everything, then we can speak to everything that we are speaking to here. Because maybe my last question, I had challenged ourselves and challenged the doctors and challenged the surgeons. The first challenge was, if the doctors can't save their doctor, if the doctors can't save one doctor, can they convince the population they can save us? The next question I asked was the population. If you don't realize the importance of a doctor, because we should not be fundraising, we should not. Or if we are calling for a fundraiser, it takes only a day because we know what a doctor is to us. And I spoke in a video. Doctors saved me when I had a strangulated hernia. I'm a health professional. That some of you could not afford what I'm talking about. I was saved by doctors when I had a hernia, a strangulated one, and I was saved on 6th floor in Mulago. Then I again broke my arms, both of them, and I was saved by orthopedic surgeons in Mulago. Now, if you have ever been saved by a doctor, if any of you here attends to a doctor, this is the reason we're here. Thank you so much, Dr. Kalyesubula. I salute you. Thank you.
Thank you very much again. That is absolutely appropriate, and again, it is down to citizen citizen participation. So in other words, it's up to us, the citizens, to demand actually for better conditions. It is a human right. Healthcare is a human right, and people need to know that. So it is not a service that we should be begging for. It is not a service that Dr. Anthony should be begging for. It is a human right, and but as citizens, I think we need really to demand to be louder and to amplify our demands. Yes, Comrade Sarah, your question, please. Thank you.
Yeah, thank you so much. It's a quick one, and it's in it follows up what Dr. Kalyesubula said earlier on. We're looking at the two groups of people who are on constant checkups for kidney issues, but yet again there is another group that is ignored, like people who are diabetic and who have high blood pressure, and obviously people on chronic medicine. My question here is, and it's the final one, is there any plans to create awareness? Because obviously, if there is this group of people at one point or another, and the numbers, as we have seen, are growing, the numbers of people with kidney failures, and the numbers are growing. So is there a campaign? Can there be a campaign? Because I feel like this is not only about the ministry, but it is about every citizen to get involved as long as they're aware of this. So Dr. Kalyesubula, would you probably look into maybe getting a few people together, working with the ministry? I don't know what needs to be done, but to create even just campaigns in major hospitals. You know, when people go to hospitals, you see, or they're encouraging people to immunize their children, or to do this, or to, why isn't there information in hospitals, in health centers, encouraging people to do regular blood tests for kidney to see how their kidney is functioning? This could save so many people, and it could actually also put less pressure on the system, as well as the country at large. So yeah, it's about campaigns in hospitals. Thank you.
Over to Dr. Kalyesubula, please. Thank you.
Thank you very much. I hope you can hear me. I often get into trouble with my network.
Loud and clear.
I think that's a pertinent question. Yes. I want to first appreciate the previous speaker. It is to rise up. We need universal health coverage. Kenya, Tanzania, even Rwanda are now able to provide dialysis to all their citizens for free. So it is the citizens that actually will play a big role. We need universal health coverage for Uganda. That would be a first ball rolling. Now, to answer the question about screening, yes, it's important. I think this is very but we're here for ourselves, because of us can be a victim. But people heard me initially, when we screen for disease, the WHO has a criteria of about 10 lines. One of them is that, of course, you should have the treatment once you find someone who is sick. So before you go screening everyone, ideally you should have a positive remedy for whoever you find sick. But that's not the key point I want to make. The point is that world over, we don't routinely screen for kidney disease. Why? Because it's not cost effective and our tests are not 100% specific. They might label people who don't have kidney disease as if they have kidney disease, and at times they might also miss those who have kidney disease and label them as not having kidney disease. As such, we have a particular population which is those with hypertension, those who have high blood pressure, on chronic medications. Perhaps everyone who presents to hospital with a disease should be screened, but it's not like immunization where you are giving it to everyone. So there is cost effectiveness that is done in studies, and kidney disease does not meet the mark of screening everyone. So those people increased risk that should be screened. I agree with the previous speaker that this should be taken regional. It should be on public television. We should engage the Ministry of Health. We should develop appropriate messages. And I think each one of us here has the capacity to do that, as the previous speaker said. This is not only to us. As you see now, Anthony is sick, and we are all here for him. But anytime, any date can be any of us. So I want to submit to the team today that it is our responsibility for all of us, especially if we know about those who are at increased risk for kidney disease, to ensure that they get tested. I submit. Thank you very much, Chair.
Thank you so much, Joe, Sarah, and James, for leading this. On my own, in my own capacity, I'm very, very grateful, but even on behalf of Dr. Anthony's family and the fraternity of doctors in Uganda, I believe this window is opening up a revolution on many fronts. So thank you so much. And for everyone that has logged in, for everyone that has retweeted, that has tweeted, that has shared the poster that has Dr. Anthony's face as well as his phone numbers and bank account. Thank you for sharing and reaching out. I know many of us on the call have already given it some money. Thank you so much. And I believe this journey of saving Dr. Anthony, it looks a lot easier today than it was a week ago. And I believe at the end of this journey, there will be many wins for Dr. Anthony as an individual, his family, but even for the medical fraternity in our nation, as well as the Uganda populace at large. Thank you very much. I do pledge to reach out to the leadership of Uganda Medical Association. Thank God even Dr. Actually, I also want to thank Dr. Robert Kalyesubula, is my teacher, and for taking off time to be here and for all the good information he has shared. Really, it's been so helpful to me, but everyone on this call. So thank you so much, and we look forward to the next space, and I believe we'll have a better report in terms of cash received. Thank you so much, and God bless you all. Good night from Uganda.
Thank you very much, Dr. Nyanze, for those very, very inspiring words and very encouraging words. That is what we need now, giving hope. Yes, Dr. Mgeni, please give us your closing remarks.
For me, I think I'll react to Dr. Judd. Was it Judd who we didn't ours is an effort. We decided to join because the flyer is out there, and for us, we are activists. Everything that affects humanity affects us. So we saw it and we went for it, and we are happy. You are speaking to us. We are happy. We are now a community. And I think even Martha now knows that she's global and followed. This thing, this small space we made has, I think, given her even a counselor which is okay. And this is Gwanga Muje, in a simple language, Gwanga Muje. But as Gwanga comes, where are we going? It's a very important question that all of us must answer. Some of us will speak from the first world, and when you see what is here, you ask yourself, why God answers prayers here? Because we pray more than here. You cannot talk about prayer in the United States, but guys, people live here better. I'm in a hospital, like I've said, kidney transplant, heart surgery is ABCD, like we're treating malaria in Africa. So as a country, as a community, I liked what Dr. Nyansi has said. It's the beginning of a revolution. And the revolution is positive. A revolution is about us. Which country do you want to live in? Do you want to live in a country where people fundraise for you? Sharing doctors' information online, for example, those who know the ethics, it's uncalled for. But we are doing it because we are desperate. We are thrown into destitution. The 4Ds, disease, disability, destitution, and death. That's what we have seen here. Now, we must address this. We have the capacity to address this. And like I said, in the United States, we say, when the country fails, the only option that remains is you. It's you. So, guys, I think my last call is, we are going to have another space. We are still going to have another space. When you come with another person. Let's build up this community. It's called building up a community in primary health care. It's a community diagnosis. Now we are headed to our own solutions. Uganda was known worldwide. We are the first country in the world to start primary health care, and the rest of the world followed us. We have just regressed. Yes, Kasangati was the first place for primary health care in the world, and the rest of the world followed us. Look at Tasso. There is no other example in the world better than Tasso. That is community effort. So we are building up a community, and like Dr. Nyanzi said, it's a revolution. Thank you so much.
Thank you very much, Dr. Mgeni. Very powerful words indeed. I think this is the trigger that we've been waiting for. It is a watershed moment, and really, let's follow one another. Let's begin networking, and let's maintain this cohesion. And exactly, we need to put pressure to bear on the duty bearers, on the decision makers. We should not take things for granted. Health, healthcare is a human right, and this must be made very, very, very clear to the duty bearers. If they're forgotten or if they don't know, we must put that pressure. But going forward, it's really good that I think UMA is going to be involved, and it should really be spearheading this. Final words from Dr. Kalyesubula, although he had said, please give us your final words, Dr. Kalyesubula. Thank you.
Thank you very much. I want to thank the organizers that ones attend today's talk. I think focusing on so as a kidney doctor, I would also like to urge each one of us not to stop at Anthony, but to look at kidney disease as a wider problem, but more importantly, the health system as a whole. And as everyone has spoken, I think this should be a springboard for us to get something durable that will not only help doctors, but also help the common man who's seated in the village. I want to thank you for listening to us. Thank you very much.
Thank you very much, Dr. Kalyesubula. Indeed, I think this is the trigger that we needed, and really, this is a springboard. And I think we are going to begin having further discussions. How do we broaden our outreach? How do we challenge the status quo, and how do we push for reforms, for change? We cannot continue living in almost 1800 century kind of system. Our healthcare system is broken, is not fit for purpose, and everybody knows that. That is why the political class fly their people out. They do not dare to have their people treated. What about the majority of us? What about the 45 million? We deserve better, and we must fight for that. Yes, Comrade Galogitho, your final words, please. Thank you.
Thank you very much, members. Thank you so much for coming. Thank you for your commitments. Thank you so much. We still have a lot of work to do. Let me just say, I wanted to remind us of one strategy which we could also use. You know, we are trying to reach out to many people. I understand there are about 1,900 intern doctors in Uganda, 901 intern doctors in Uganda. I was trying to get in touch with Dr. Shamim Nambasa. I don't know their leadership. If we could reach out to these intern doctors, to each of them to give us 30,000 shillings, we could easily raise 50 million from the intern doctors alone. So what is bothering me is the strategy for raising money as quickly as possible. When we are done with this, we should go back rigorously into rigorous advocacy and campaigns. If Kenya here, the Kenyan health system was born in Uganda, all those doctors in Kenya trained from Mulago here. Tanzania, why would they give free dialysis when we are here suffering? So that is an issue for another day. But thank you very much for bringing all those suggestions. Let us work very hard to see how we can raise the money, how we can raise money to save Dr. Anthony. That's the most important thing now. We shall talk about all these other diseases after 1 month, after we have taken Dr. Anthony and saved his life. So thank you very much. Let's keep on going. I don't know when we shall have another space. Let us get people participating. Let all the doctors in Uganda participate in this. Nobody is going to leave this country alive, and you must pass through doctors. You know, when you save a doctor, you have saved the nation. Let us wake up with this issue of Dr. Anthony. Thank you very much. Thank you, colleagues. Thank you, comrades. Thank you for coming. Thank you so much. Goodbye until we meet again.
Thank you very much, Dr. Galogitho. I don't need to repeat anything. Everything is very, very crystal clear. Indeed, yes, we need to mobilize more. Finally, Comrade Sarah, your thoughts, please. Thank you.
Thank you. Thank you so much, Joe. And thank you everyone who has joined this space today, who joined this space last week, and who will probably join us in the future. And thank you to everyone who has contributed so far. And thank you to those who are yet to contribute. Please do share the campaign, the GoFundMe page, and the mobile numbers that are on the flyer so that we get this done as soon as possible. I'd like to thank Martha for staying with us here. I'm sure she wasn't able to talk because she's in Kirudu at the moment, but yeah, she's listened in. And anyone who missed last Tuesday's space where Martha gave us a profile of the doctor, it will be shared on the Transitioning Uganda page, so you can listen. And if anyone wants to know a bit about the doctor, they can find out from that brief that she gave us. Thank you. Until next time, be nice. Thank you.